So in this section, we will talk about how to take a gynae history in a structured manner. The role of a doctor is actually listening to the patient tell her story, and from the story, we generate a hypothesis or a diagnosis. This diagnosis obviously is made up of 50% by interrogation, 10% by examination, and by investigations, the rest of which is 40%. If we don't come to any conclusion, the best way of doing it is obviously we've missed something in the history. The idea would be to go back to the patient and double check their history and come to a conclusion next time. The idea of this slide is to emphasize the importance of history taking, a thorough, good, structured history. Some considerations before we start the history. In gynae, the history-taking sequence essentially remains similar to as in case would be a medical history. So therefore, we follow a logical and a chronological sequence of history of presenting complaints, past medical, surgical history, and so on. However, in gynecology, there are some specific areas that we need to focus on, and I will touch upon these in the next slide. Gynae history is a bit peculiar in the sense that it requires sensitive history and confidentiality is important. We also have to ensure the dignity of the patient, and this should be communicated to the patient. Possibility of pregnancy should always be considered, especially when there is history of abnormal bleeding or pain, although the patient may not bring this as a diagnosis. We come to presenting complaints. So, as mentioned, gynae history usually follows the same history-taking sequence. However, there are some key areas that we need to focus on. I will delve into the details of these in the next few slides. Some of these are menstrual history, the common gynae issues, for example, vaginal discharge, pelvic mass, abdominal mass. Contraception and sexual health is an essential component of a gynae history, which we shall talk about. Although detailed obstetric history is not required, we do require basic obstetric history even for a gynae complaint. Urogynecological history may be of relevance and will also be considered. Pap smear, details of last pap smear and vaccination against cervical cancer would also be an essential component of this history taking. Past gynae or surgical history would obviously complete the entire history sequence. So, firstly, we will consider menstrual history in details. So, there are certain patterns of abnormal menstrual blood loss, and we shall define these first. We often hear about menorrhagia. Menorrhagia means excessive menstrual blood loss at regular intervals. There is also a terminology that's used quite frequently, that's metorrhagia. That means frequent and irregular menstrual blood loss, which may be out with the normal cycle. Polymenorrhea. Polymenorrhea means a cycle that occurs too frequently, that is less than 21 days. Oligomenorrhea means infrequent menstruation or scanty menstruation, usually occurring after gap of more than 35 days. Intermenstrual bleeding is bleeding in between the menstrual periods and has to be defined quite clearly whether it follows a cyclical pattern or not. It therefore requires careful questioning. There are some tips of obtaining a good menstrual history. An easy way to begin is tell me about your menses. We also need to focus on the age of menarche, usually in younger patients. Obviously, in some cases, it may not be of relevance. The last menstrual period is very important. What is more important is to get the date of the first day of the last menstrual period. As often the patients give you the last day of the last menstrual period. Also important to know whether the last period was normal and whether it arrived at an expected time. Also ascertain the pattern of bleeding. Was it normal or was it abnormal? Important to know how often the periods occur, whether they are regular or irregular. We therefore have to know whether they come too early or too late. It's important to understand that the periods not every cycle needs to be 28 days. the periods are considered normal between 21 and 35 days. And usually for most people, it happens between 28 to 30 days. Also, another question would be, how long do they last for? And this would include counting from beginning of one period to the beginning of next period. Further on in menstrual history, it's important to estimate the menstrual loss in order to diagnose a case of menorrhagia. This can be often challenging. Some questions that can be asked are, how frequently do you change your pads? Was your pad completely soaked? Was there any clots or flooding? If they do not understand the term clots, you can ask whether they pass any tissues or liver-like substance. Dysmenorrhea is another important symptom, so you need to ask whether the periods are painful, and are they more painful now, or how bad is the pain in terms of mild, moderate or severe. And when does it? Timing of the pain is important as it gives you the diagnosis whether it's primary or secondary dysmenorrhea. Severity. To assess severity, one important question is, does it keep you off work or school? Also important to consider any recent change in the period pattern, any post-coital bleeding, that is bleeding after sex. Important to know about post-coital bleeding. Post-coital bleeding can be an important sign of cervical cancer, or it can be often related to a benign condition known as cervical ectropion. Intermenstrual bleeding can be a sign of infection, can be hormonal, or can be related to polyps. Hence, it's important to establish whether it's cyclical or non-cyclical. Coming back to menorrhagia, as this is the most important presentation in gynecological clinic or in an A&E related to gynae, it's loosely defined as excessive menstrual blood loss. What is excessive menstrual blood loss? Let's talk about it in more depth. When the menstruation escapes the normal menstrual protection, it may be excessive. When the patient passes large clots, and that too for 2 or 3 days, it can be excessive. When the patient has to get up more than once to change her pad at night, the menstruation is considered excessive. Also, when it lasts longer than 7 days of full flow. Normally, the menstruation would be heavy for day 2 or day 3 and then becomes less frequent to last for a total of about 7 days on average. When excessive menstruation interferes with normal life or duties, or leads to a change in lifestyle, for example, a patient wearing dark clothes during her menstruation for the fear of getting flooded. Also, when it leads to iron deficiency anemia, despite supplements, when we have specially excluded other causes of anemia. So, let's talk about obtaining a detailed history for heavy menstrual bleeding or menorrhagia. It is very difficult to ascertain and can be subjective. However, it's impossible or impractical to try to ascertain it objectively, as this would mean collecting menstrual material, which is impractical. Therefore, we have to ask in detail about the number of towels or pads used, whether they were fully or partially soaked. We also need to ask about whether the blood clots were normal, whether they were small or whether they were large, and how frequently they were passed. As mentioned, flooding is menstrual blood that soaks through all protection and stains the clothes or even bedding in extreme cases. It is often abnormal and distressing, and sometimes the patient has to be questioned about it and will not be forthcoming about this as they may be embarrassed. Getting up at night more than once usually means menorrhagia, so you have to ask how many times do they get up, and do they get up every night, or is it only once or twice? It's also important to know whether the heavy menstrual bleeding actually interferes with their life. Have you had any accidents related to your period, means menstrual protection staining your clothes at time of work or school? Or do you have any associated symptoms of anemia such as feeling tired, run down? This may also be related to hypothyroidism, hence it's important to ask about symptoms related to hypothyroidism as well. Let's talk about oligomenorrhea, scanty menstruation. Often put loosely, it means irregular periods, and it suggests anovulation or irregular ovulation. Amenorrhea means total absence of periods. Amenorrhea may be primary, which means menstruation has never been established. If the girl is 16 years old with secondary sexual characters and has never had menses, then she suffers from primary amenorrhea. The other way to define it is when she is 14 years old but does not have any secondary sexual characters, this would also be diagnosed as primary amenorrhea. Amenorrhea can also be secondary, which means absence of menses for more than 6 months in continuation. It's important to remember that the most important cause of secondary amenorrhea is pregnancy. So the first step would be a pregnancy test to exclude that cause. Oligomenorrhea means infrequent periods with a cycle of more than 35 days. It's important to ask specific questions related to anovulation. The first question would be any recent weight change. So excessive weight loss or weight gain is important. Weight loss, as in athletes or in people who exercise heavily, or in girls related to anorexia nervosa, may lead to hypothalamic suppression and hence amenorrhea or oligomenorrhea. Excessive weight gain is often related to polycystic ovarian syndrome, which also is associated with anovulation and oligomenorrhea. Polycystic ovarian syndrome also is associated with acne and greasy skin, and this should be a leading question. Hirsutism or abnormal hair growth, for example on the chin or on the chest or other facial areas, is also a sign of PCOS. Also important to consider would be hyperprolactinemia, and for this we need to question about galactorrhea, that is any discharge from the breast or nipple, and recurrent headaches, as this would require specific investigations including hormones and imaging. Hyperthyroid symptoms are also important and should be inquired. Not to forget about menopause. Although menopause is expected in either late 40s or early 50s, it is not uncommon to have premature menopause in a woman younger than that, and therefore one should always ask in oligomenorrhea and amenorrhea about hot flushes and night sweats. Coming back to dysmenorrhea, let's ask detailed questions. So as mentioned, the dysmenorrhea is considered primary when no significant cause or no organic cause for a disease is found. It usually begins with beginning of bleeding or menses, lasts for first 2 to 3 days, and usually improves once the girl matures or has children. Menorrhagia may be secondary when it's secondary to some second pathologies such as endometriosis, fibroids, or chronic pelvic inflammatory disease. This usually begins few days prior to the menses and gets better once the bleeding begins. Obviously, this would be associated with other signs of the associated disease. It's important to ask about severity of dysmenorrhea, as a severe dysmenorrhea will lead to time off work or school. Is this a recurrent feature? Would also be an important question. Important also to consider any aggravating or relieving factors of the disease. Do they take painkillers? If so, do they take it regularly? And does it make the symptom better? Is an important thing to consider. Also important to ask about family history of conditions such as endometriosis, as endometriosis is known to run in families. Another important presentation at the gynae clinic is vaginal discharge. Let's talk about it next. So important to know how long the discharge has been present for. Is it cyclical? That is, does it become more during a particular part of the cycle? As we know that during ovulation period or post, the discharge is thin and mucousy. Prior to menstruation, the discharge becomes thick and whitish, and this is hormonal and normal. Is there any associated symptom of the discharge, for example, itch or any odor? The amount of discharge is also important to document. The color of discharge can help you with the diagnosis. So white discharge may be either physiological or related to thrush. Yellow or greenish may be related to an infection. And brown discharge may give you an idea that it may be old blood or altered blood. The odor is usually normal in case of physiological discharge. However, the odor may be typically fishy in case of bacterial vaginosis. Is this a recurring feature or have you had this in the past would be important to know. Have you used any treatments, as sometimes recurrent courses of antibiotics may lead to thrush. So important to know any other treatments related to treatment of infection, as often the infections can be partially treated. Any other symptoms such as pain or fever may indicate pelvic inflammatory disease, which is an important cause of vaginal discharge. Patients may present to you in the clinic with a mass in the abdomen. So let's see what questions we need to consider. So how long has this mass been present? Has there been a change in size? Has it increased recently? Is there any associated pain or tenderness? Does it hurt when you touch? Any associated symptoms such as nausea, vomiting, or recent constipation or diarrhea? Any weight loss? Weight loss can be associated with malignancy and is an important part of the questioning. Any other symptoms to consider would be heavy menses or amenorrhea, as heavy menses with a mass would be a feature of fibroid, and amenorrhea can be related to a pregnancy which can often present as mass. Let's talk in brief about urogynecological history. Easy way to begin is any problems passing urine. The common urinary symptoms are urinary frequency, getting up frequently at night to pass urine, pain passing urine, any urinary incontinence, and also blood in the urine, etc. Incontinence has to be defined in terms of whether it is related to stress or urge, which carries different diagnoses. So to ask about stress urine incontinence, good way to begin is, do you leak urine when you don't intend to? And is it related to or provoked by certain acts such as coughing, having sex, or heavy exercise? This is a feature of stress incontinence. Urge incontinence is related to aging and usually found in postmenopausal women. Good way of questioning is, do you ever make it to the toilet in time? Can you hold your urine without leaking? Another way of questioning is, do you pass small volumes of urine quite frequently? The patient may also present with a mixed picture and may require further investigation. Another important presentation of urogyne is prolapse. So it's important to ask about symptoms related to vaginal discomfort, feeling of a lump or something coming down, especially after exercise or heavy work. Let's talk in brief about obstetric history, which would be covered in another section, but is relevant to a gynae patient as well. The number of previous pregnancies is important to know and should be documented. It's also important to know number of children, as some of these pregnancies may either be miscarriages or terminations. Birth of a big baby is related to prolapse. Any problems during pregnancy or labor? What was the mode of delivery? Was the labor very prolonged? As prolonged labor and delivery of a big baby can be related to or positive of prolapse. Any terminations or miscarriage? If so, what was the procedure? Whether it was surgical or medical, and at what gestation did it occur? Sexual history can often be intimidating. It's important to approach it in a sensitive and structured manner. easy way to begin is I need to ask you some personal questions. I hope that's okay with you. The patient may never have been sexually active. Therefore, this must be considered, and usually one should begin with, are you or have you ever been sexually active? It's important to know the age of first intercourse. Therefore, this should be documented. Also important to know whether they have, how many partners they've had in the last 6 months, as having more than 2 partners in the 6 months could increases the risk of having a pelvic inflammatory disease. When was the last time you had sexual intercourse is an important leading question, as this would give you an idea of chances of pregnancy and also the risk of pelvic inflammatory disease. Also important to know whether they've had any sexually transmitted infections in the past or they've had any sexual assault or incest. Another important point to consider is domestic violence. Therefore, this should be questioned when appropriate. And finally, few other things to consider. Previous gynae problems such as sexually transmitted infections, endometriosis, infertility, any gynae surgery, any polycystic ovarian disease may have a bearing on your history and should be inquired about. Contraception is very important. Therefore, important to know about current as well as past contraception. Any abnormal or irregular bleeding may be related to progesteronic contraception and should always be asked about. Therefore, important to know whether the contraception is hormonal or non-hormonal. In non-hormonal contraception such as IUCD, can be related to dysmenorrhea and menorrhagia, and therefore the importance of knowing the type of contraception. Any problems with the current contraception, as they may require a change of contraception or further advice. Pap smear history is an integral part of the gynae history. One should always ask about the date and the result of the last cervical smear. Any treatment related to colposcopy or abnormal pap smear in the past. Also important in today's world to know about any vaccine against cervical cancer. So details of that vaccine, the duration of that, and when was the last injection taken would be important. Any bowel symptoms such as bleeding PR, fecal incontinence, bowel habits, mucus in the stool, and difficulty emptying bowel may have a bearing on the gynae diagnosis and are important to consider to complete the total gynae history. I would like to thank you for your attention. Your questions can be directed to me via email, which is as below.